Good afternoon, everyone, and welcome to the TxRx Medications for Substance Use Disorder ECHO, brought to you by Bevel Texas at CSTAT. Please note that we are recording these sessions for later distribution. Anything listed in the chat will not appear in the recording. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, email, and affiliation into the chat. To access the chat feature, click on the speech bubble icon at the bottom of your navigation bar of the window. If you are one of our Bevel Texas providers, please make sure that you identify yourselves during this session. If you are joining via phone, please email your name and phone number to beveltx@unisca.edu. Some housekeeping. Please stay muted unless you're speaking, and we do encourage you to speak. If you joined by computer, your mute button is at the bottom left of your Zoom controls. If you're on the phone, just press *6 to unmute. We encourage everyone to speak at these sessions, especially during the discussion portion of the session. We want to hear from as many of you as possible, so please keep your comments brief to allow time for others to speak up. You can also use the chat feature to share your comments or questions. Please note that no protected health information is allowed in either the chat or the discussion, and that includes names, emails, addresses, or anything that can easily identify an individual. If you would like to view closed captioning for this session, please navigate at the bottom of your Zoom window and select the Show Captions option. Towards the end of the session, the Bevel Texas team will send out a link to an evaluation survey. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Our didactic today is on suicide prevention in persons with substance use disorder, and this will be presented by Dr. Crystal Walker. Following that, we will discuss a case presented by Dr. Angela Nash. We will start with some introductions, followed by didactics, Bevel program announcements, and case discussion. Thank you all again for joining today's ECHO. We look forward to learning alongside all of you and encourage you all to share your questions, experiences, and insights in today's conversation. And with that, we will do some introductions. Dr. Walker.
Good morning, everybody. Crystal Walker, Director of the Substance Use Disorder Clinical Services at MHMR of Tarrant County, and you'll be hearing more from me shortly.
Thank you so much. Dr. King.
Hi, I'm Ben King. I'm addiction psychiatrist, professor here at UT San Antonio. Welcome, everybody.
Thank you so much. Dr. Angela Nash.
Hi, I'm Angela Nash. I'm a pediatric nurse practitioner that's board certified in primary care, mental behavioral health for pediatrics and addictions. And I'm presenting a case for my Young Heroes practice.
Thank you so much for joining us today. Jasmine Vidal.
Hello, everyone. My name is Jasmine Vidal, and I'm the TxRx program coordinator. Thank you for joining us today.
Thank you. And with that, we will move on to our didactics. Dr. Walker, you can take it away whenever you're ready.
Okay, perfect. Let me get this slideshow started. Everybody see that all right?
Yes.
Perfect. Okay, so again, the topic is suicide prevention in persons with substance use disorder. So this is a pretty heavy topic to cover in just 20-30 minutes. So we'll try to get through the highlights today. I have no disclosures, and these are some of the things that we are going to be discussing. This is mainly going to be a bird's eye view of how an organization could potentially implement a suicide prevention pathway and give kind of the building blocks of what suicide prevention looks like in an organization. So why is this important? Well, we all know that there is a large number of individuals in the United States who have both substance use disorder and mental illness. And according to the 2021 National Survey on Drug Use and Health, about 20% of our adult population has either a substance use disorder or a mental illness. So here's an even bigger issue with that, is that out of those individuals, 47.5% in 21 had no treatment for their substance use or their mental health. Out of the ones that did have treatment, only 13% had comprehensive treatment, including both substance use treatment as well as mental health services. Most of them only received one or the other. So making sure that we have a really well-rounded, well-educated workforce in both the substance use realm and the mental health realm that can cross-cover both of these situations and diagnosis is incredibly important. And if we zoom in on Texas, the statistics are pretty dire. We have had a 38.1% increase in Texas in our suicide rate since 1999. In addition to that, just in the 4 years between 2016 and 2020, we had almost a 12% increase in ER visits for suicide attempts. If this is broken down, which the American Foundation of Suicide Prevention did, this means about one person every 2 hours in Texas dies by suicide. In addition to that life that is lost, approximately 135 people are affected in some way by that suicide death. So this is a very far-reaching, impactful situation for many of our patients and many of us probably on this call. So what do we know about this? We know that suicide is a public health problem and that it is preventable, and that the majority of people that die by suicide aren't connected to the mental health services that they need. And not only that, that survivors of suicide are at increased risk. People with a history of trauma are at increased risk. But there are ways to reduce this risk. There was a great publication by Mann et al. Back in 2005 that kind of laid out the pathway of what leads to a suicidal act. He recently revamped this and published it again in 2021, highlighting the prevention interventions that are effective. And by effective, they mean, does it prevent a suicide attempt and is it evidence-based? So those are the elements that are bolded. So each section in this pathway, when it starts with a stressful event or a mood or psychiatric disorder or acute intoxication that leads to the suicidal ideation, that eventually leads down to the suicidal act itself, each element has a potential prevention intervention, whether it's awareness and education, screening for individuals that are at high risk, treatment, and there are a lot of treatment options, pharmacotherapy, psychotherapy, etc. And then we have follow-up care and means restriction. We're going to get into each one of these elements a little bit deeper, but I wanted to share this because this could be used to develop a system-wide protocol or a pathway to care for each of these elements in someone's organization. So how exactly is Texas addressing suicide prevention? There are quite a few things going on in Texas right now. One resource that can be used is the Texas Suicide Prevention Collaborative. And we'll touch base on this a little bit more when we talk about trainings, but they have a lot of resources, and I included the website there for you guys at texassuicideprevention.org. We also have a Texas Suicide Prevention Council that just put out a 41-page PDF that I didn't think we could cover in this 30 minutes, so I wanted to tell you about it in case you wanted to access it yourself. It's easily Googleable, and you can download the PDF and read through it. But it's the Texas State Plan for Suicide Prevention for the state of Texas from 2023 to 2028. And this is funded in part by the Mental Health Block Grant. There's also in September, which is Suicide Awareness Month, going to be a Texas Suicide Prevention Symposium in Mesquite, Texas. If you guys are interested in that, you can find a way to register for that. Now, one of the things that I'm going to dive a lot deeper into today is the Health and Human Services Suicide Care Initiative. So what is the Suicide Care Initiative? So in the state of Texas, this program has divided up Texas into 4 regions, and each of those regions has a regional suicide care support center. So you can see all of the regions and how they're highlighted, and there's Integral Care, my company, MHMR of Tarrant County, the Harris Center, and Tropical Texas Behavioral Health. So if your agency is looking to initiate something like this, I wanted to make sure you knew that there was a resource that you could reach out to help implement something like this. So what the Suicide Care Initiative does is it's implementing the Zero Suicide Framework into LMHAs, LBHAs. So what exactly is the Zero Suicide Pathway? It contains 7 elements. These 7 elements, this slide, in addition to all of the slides that we're about to go through, the bolded and things in quotation marks come directly from zerosuicide.edc.org. So if you're interested, the great thing about the Zero Suicide Framework is how much readily publicly available, not behind a paywall, resources that they have on this website. So we're going to take the time to go through each one of these elements briefly. So in order to have a good suicide prevention, you need leadership. You need to have a system-wide change that is multimodal, multifactorial, that goes through that pathway that we showed, right? It's not just giving someone a prescription. It's not just getting them with a counselor. It is multiple elements at every pathway in that journey that we can have an intervention. So this starts with getting buy-in from leadership. And a good way to do that is to have a champion, have somebody that is championing for this change. And also to make sure that there is input from all areas of the table, from the peers, from the substance use department, from the prescribers, from the counselors, from the social workers, so that they can input into which of these elements would work, may not work, what barriers are there. And having more voices at the table will get more buy-in just in general from the agency. Because if your agency is anything like some of the agencies I've been in with, there are a lot of initiatives, a lot of noble initiatives, but staff are kind of like, let's wait and see what's going to stick before we put a whole lot of time and energy into this, because so many initiatives can be brought up. And culture shift in an agency can take anywhere from 18 months to 3 years. So you need some champions and some, initiation committees to really make sure that once it's off the ground, all of these elements are followed through. So biggest element is going to be training your staff and putting forth the effort to make sure that all staff, clinical, non-clinical, commensurate to their roles, are trained. And the training should include what the new policies and protocols and procedures are, screening elements, screening tools, how to identify what the risk factors are, what protective factors are, what are warning signs, and also the elements of assessment and how to assess individuals appropriately who are suicidal. So some of the training examples, one that I had mentioned before, the Texas Suicide Prevention Collaborative, has a wonderful training. It's anywhere from an hour and a half to about 3 hours, depending on who is giving it, called Ask. And this is what they refer to as gatekeeper training. We have had all of our front desk staff, all of our clerical staff, our kitchen staff, our residential technicians take this training so that everyone is empowered to know some of the signs and symptoms and what is, again, commiserate to their role. What can they do? Because they're not clinical, they're not medical, but they still have a role to play. So the Ask training was that gatekeeper training, the people that they may encounter first that can have a very high impact on their course of treatment. Then, of course, there's the more in-depth training, such as assist or mental health first aid. And then there are interventions that individuals who are providing these interventions will need to be appropriately trained on, such as counseling on access to lethal means or CALM, collaborative assessment and management of suicidality, or chronological assessment of suicide events. All of these can actually, most of these can be found through either the Health and Human Services website, and they will help take you to the platforms that will provide these trainings, or start with the Zero Suicide Framework, as they also have many of these trainings available. So training staff, very important. And one of the things they should be trained on is screening. So that's the next element we need to look at, identifying. So we need to identify every new and existing patient for suicidal thoughts and behaviors in an ongoing, systemic way using standardized tools. So there are multiple tools out there, PHQ-9, the Columbia Suicide Severity Rating Scale. We call it a scissors because it kind of looks like the word scissors. And then the Beck scale for suicide ideation is used frequently in some of the case studies we may mention a little later, and then the Ask Suicide screening questions. Now, many places that don't focus on mental health may not use the more in-depth suicide screening tools, but PHQ-9 is a great general patient health questionnaire that is more focused on depression, but question 9 hones in on the thoughts that you would be better off dead or hurting yourself, that suicidal ideation component of it. So to take a little bit closer look at the PHQ-9, the reason why it's named that is because it is 9 questions. And the 9th question focuses in on the suicide ideation. Now, the one that our agency uses is both the PHQ-9 and the Columbia scales. This is the Columbia screener. So we initiate it with a screener, which is just 6 questions. But if they score high on this screener, we go to the full assessment, which you can see, this is a lot of words. I don't expect you to be able to read all of this. I just want to show how in-depth the questions are. And this screening really allows for you to dig in to each question, and it helps guide the person giving the screening on what questions to ask to determine the extent of the suicidal thoughts and the acuity of the situation. Now, the next element is engagement. Granted, the Zero Suicide Framework is only looking at individuals typically presenting in an outpatient with suicidal ideation. So first and foremost, we need to make sure that anyone who has had a suicide attempt or is at immediate risk has medical stabilization. And if they are at imminent risk, they seek a higher level of care, such as psychiatric inpatient. And this could be an attempt with something that's highly lethal, something that includes steps to evade or hide the thoughts or the extent, or not being willing to participate in a safety plan. So these are some of the ways, this is from UpToDate, and it is a great algorithm that you can look at. Okay, are they having active suicidal thoughts or passive suicidal thoughts? And at what level do they need care? Do they need immediate transportation to an emergency hospital and inpatient stabilization, or can they be treated outpatient or in a day program partial hospitalization? This slide set will be sent out later, so you guys can read through this more in depth after this lecture today. So one of the biggest components of the Zero Suicide Framework is developing a suicide care management plan or a pathway to care. That way, every single person in the agency that is involved knows what the next step is, knows what's going to happen next. One of the big proponents of this is safety planning. So safety planning is not to be confused with a contract for safety or a no suicide contract, because there's really no evidence that these contracts are effective. So what is a safety plan? It goes through each of these elements. It goes through warning signs and takes a collaborative stance with the patient to recognize the signs that immediately precede a suicidal crisis for them. It engages their own internal coping strategies. It sets up people and social things that can provide a distraction to them, or people that are a support to them that can be informed of the safety plan. And it actually has them, it's a form that they fill out that has the person's name, their number, when they would contact them, as well as professional agencies that they can contact, and then going in depth about making their environment safe, removing access to lethal means, limiting their access to substance use or getting them into treatment. And there is a training to go in depth about how to make an environment safe called CALM, Counseling on Access to Lethal Means. Then the next step is going to be treatment. So once we have the safety plan in place, we want to engage them in treatment. So one is addressing those underlying factors, precipitating events, ongoing life difficulties, getting treatment for any underlying mental health disorders. But there are three main evidence-based interventions from a psychotherapy standpoint that have been proven to be very effective. And this is CBT, or cognitive behavioral therapy, for suicidal prevention, DBT, and CAMS. So if you want more information on that, I'm happy to share it, but there are intensive trainings that go into this that is more than what we can have time to go into today. But these have been shown to be effective treatment means for patients with suicidal ideation. So let's look at pharmacotherapy. Pharmacotherapy isn't a focal point of zero suicide, but I did want to touch base on a couple of things. Again, treatment of any underlying issues. So if someone does have depression and they are having suicidal ideation, and SSRI may be first line. However, there is less compelling data with SSRIs than there is with lithium. So lithium is considered first line treatment for suicidal ideation, for suicidal clients. This is not considering their underlying mood disorders that may need treatment. And then we want to avoid things that are very highly lethal, TCAs, MAOIs. One thing that I want to dive into a little bit that I think is very relevant for our population are the studies that are coming out with buprenorphine. So there are two clinical trials that are out there. One that looked at 51, it was a population of 51 men that were in an inpatient environment that had both OUD, or opiate use disorder, and major depressive disorder, that were actively suicidal, and they were given high doses of buprenorphine, 32 milligrams to 96 milligrams of bup, and all of them had a significant reduction in suicidal ideation when using the Beck scale for suicidal ideation. There was another case study, or not case study, but a clinical trial that was done using ultra low dose buprenorphine, so 0.4 milligrams of buprenorphine in individuals without substance use disorder, specifically for the treatment of suicidality. And it turns out that they also had a significant reduction at both the 2-week mark and the 4-week mark. They received 4 weeks worth of treatment. And then after that, the buprenorphine was stopped, and they reported no withdrawal symptoms and resolution of their suicidal ideation. And a lot of this stemmed from a really interesting case study that was done regarding a 61-year-old woman, written by Stribal et al. And published in the Journal of Psychiatric Medicine, about the 61-year-old woman who had chronic pain and daily suicidal ideation from her 50s. And she was having an opiate use disorder and was referred to a clinic. And then as soon as she was started and stabilized on buprenorphine 16 milligrams, a week later, she stated that her suicidal ideation had completely disappeared, and she had been tried on numerous medications. The thought process behind if buprenorphine may be linked to reduction of suicidality is because mental pain can be very similar to physical pain pathways, and it's modulated by the distress system that is typically controlled by our endogenous opioids. However, this is all early stages, and it is not an FDA recommended treatment for suicidal individuals. But I thought that that was very interesting for us to keep an eye out for, since we are all in the realm of treating substance use disorders and we all frequently use buprenorphine. Okay, so the next step that we need to look at is transition of care. Many individuals who have an attempted suicide and they are sent to the hospital for stabilization, the majority of them don't receive a good transition of care. 46% no mental health treatment. 60% didn't participate in any type of outpatient mental health visit. And 48% really only received prescription medication and didn't receive any wraparound services. So the Zero Suicide Framework really focuses on warm handoffs and transitions of care, because 12 months after suicidal ideation or suicidal attempts, there is a very high prevalence of suicidal death within those 12 months after that. So ensuring individuals have those services and wraparound care, warm handoffs, is a very important part of this framework. And then always improving. And what the approach that an agency needs to take is shifting away from blame and toward improvement. So shift away from, why didn't you call this client? Why isn't this done? Why wasn't that done? To, how can we improve this? What could we have done better? And one of the quotes that I really liked, because mainly I had the question myself, was, why is it called Zero Suicide? And the quote was, well, zero is a goal. And if the goal isn't zero, then what should it be? So again, improvement. We're working towards a goal. We need to shift towards that mindset. So I wanted to share with what MHMR's substance use program, the actions that we took to help engage our folks who have substance use disorder with maybe underlying suicidality, is we screen all of our patients with the PHQ-9 and the Columbia screener. We make sure that there is a workflow in place to put safety planning in for every client that screens positive. We trained all of our clinical staff on CAMS, the evidence-based intervention that I had mentioned earlier, and we gave all of our frontline staff training on ASK, that gatekeeper training. And we have a clinical pathway in our medical record. And this is what our clinical pathway looks like. It's very busy. We love color coding, but essentially if someone scores high on the scissors, the staff immediately know what to do. They know to do a safety plan. They know to enroll them in this pathway in the EHR. And then we know to contact them every 3 days until their score goes below 8. Then we shift them to a monthly protocol. And we keep engaging them in rehab, skills training, CAMS, CALM, all of these interventions until about 12 months later. We try to keep them in this pathway for about 12 months because that's where the statistics state is the highest risk for them. And after 12 months, we successfully discharge them. That's another element that we have to consider, is when is this pathway done? When is a successful discharge? And that's something that the agency would need to decide and come up with together. We also have a pathway on, what if they don't engage? What if they don't show up? What if we can't get in touch with them? Or what if they're not willing to participate? So I will leave you guys with a couple of myths, that discussing suicide will increase the chance a person will act on it. No, there's a lot of stigma surrounding talking about it, because there's a lot of misconceptions that having a frank discussion about suicide will, quote, put the thought in their head, when that is not the case. Talking about it, most of the time when done appropriately through these evidence-based methods, will diffuse the situation. And then people who talk about suicide are just attention seeking. Again, stigmatizing myth that suicide is not preventable. We've seen that there are multiple interventions that can be taken to prevent suicide, and that suicide always occurs without warning. There are many elements that a lot of these trainings, the ASK training and the CALM training, will go through in depth about how to recognize the folks that are at risk. So these are my references, and I will end my PowerPoint and I guess open it up for any questions.
Thank you so much, Dr. Walker, for presenting this incredibly difficult topic. I'll open up the floor for any questions or comments from our learning community. I see a question here from Dr. Clancy. Any thoughts on IV ketamine?
That is very interesting. So the FDA does have an approved treatment with esketamine and in conjunction with an antidepressant. And that is something that is FDA approved for the treatment of someone with unipolar major depression that includes acute suicidal ideation and behavior. Well, actually, it's not IV, it's intranasal. My apologies, but it's intranasal esketamine.
Yeah, thanks a lot. Very nicely organized. You covered a lot of ground there. It sounds like you have a great system going on there at your organization. You know, is there like a little team that sort of is in charge of this, or what's the personnel? I'm just curious.
Yes, we do. We do actually have an implementation team. Since we were one of the regional providers, we're one of the regional LMHAs that is part of this suicide care initiative. We have an implementation team, and we have a group of people that help keep the ball rolling, that helped. They had multiple people from multiple parts of the agency come up with this workflow, so that there were a lot of minds at the table, from nurses to counselors to admin, to implement this workflow. And even though we've had this workflow implemented for a couple of years now, we are still meeting frequently to say, hey, this is an element that we may want to look at, that we may want to add, because it's ongoing. And it should be that way. It should be continuously improving and looking at the elements.
Thank you so much, Dr. Walker. And please keep the questions coming in the chat. So we will move on to the next part of our session. Angela, if you could please share the announcements from BBEL. Thank you so much. To claim your CME credit, you must text by midnight tonight. Please text 10-1009-5940 to 844-502-1338. Please do that by midnight tonight to receive your credit. Next slide, please. Do you have a difficult case that you or your team have encountered? CSTAT offers you the opportunity to present any challenge your organization is encountering and receive feedback from our experts and broader learning community. You don't need to prepare a formal presentation. We will provide you a case form to assist with your case presentation. Please email us at cstat@ithaska.edu. Next slide. We invite your clients and patients to participate in a new study intended to help individuals in recovery to better self-manage their condition. We're looking for patients in buprenorphine treatment for opioid use, aged 18 and older. Please contact us at bwelltx@ithaska.edu if you're interested. You can also scan this QR code. Next slide, please. Join CSTAT for our session titled Fortifying and Strengthening the Workforce for Future Public Health Emergencies. This will be on Tuesday, July 23rd at 12 noon. We will drop the link for registration in the chat. Next slide. Our next TxRx session will be on August 20th, and we have Dr. Antoine speaking, presenting the didactics. And with that, we will move on to our case. Angela, if you could please share the case form, and Dr. Nash, you can take it away whenever you're ready.
Do I need to share it on my screen?
No, we will be putting it up here.
Oh, you're doing it. Okay, great.
Yes.
Thank you.
Mhm.
Yeah, I look forward to this case. So I'm Angela Nash. I've had about 11 years experience working with youth who have substance use disorders. And I'm an associate professor at the School of Nursing here at UT Health Science Center. And I work for the UT Health Heroes program. It's, you may know of it. It is a program that's basically a research project to assess and prevent opioid overdose. And I see the young kids, the ones under 18. And we have most of the patients that we see here, the referrals we get are from rural areas. In Houston, the UT Health Heroes is in the medical center right down kind of the southern part of Houston. But people come from all the way. There's a huge problem in a small town about an hour and a half north of Houston, where there's just a rampant fentanyl in the form of Percocet, counterfeit Percocets in the schools. And we've started getting referrals from that area. Parents have found out about us. And I'm going to present today, I do treat with Suboxone if they are, we are a research project, and so we had to go back to the IRB, but originally we were only able to treat 16 and above because that's FDA approved, although people treat younger kids all the time. But we went back to the IRB to get permission to treat down to age 15 because of this particular case. So it's actually a group of siblings. They're 15, 16, and 17-year-old boys. And they all use cannabis and nicotine and fentanyl. So they started vaping nicotine, and I haven't gotten the story on when they started smoking, but they vape a lot. And the youngest one actually does the most with his nicotine. The elders, they describe just casual use or later in the afternoon. They use cannabis. They've been using cannabis since they were 12 years old, each of them, and they were using quite more frequently. I see them separately, so I get different stories from each of these young men, but they are, right now, I think they're smoking three, sometimes 7 days a week. And it's vape and it's concentrated, and they've been using that for a long time. Last fall, they began using these counterfeit Percocets, and they escalated very quickly. The thing about these siblings is they're incredibly close and they do everything together. And they were, so they would use 10 to 12 of these counterfeit Percocet daily. They crushed them, broke it into 3 lines, and shared to snort them. And they escalated from just trying to using huge amounts every day. And the oldest one started selling these pills in school to make money and to support their habit. And then their mother found out back in April, and they've all 3 been in trouble at school. One of them had charges. He was supposed to go to court in July and didn't. They rescheduled his court. The 16-year-old was caught with powder on his phone, so he had to write an essay. The youngest one is supposed to attend alternative school, but their mother took them out of school because she felt like it was a bad environment. And so essentially what they do is they stay home all day, except for the oldest one has a job at Burger King. And anyway, they all met diagnostic criteria for severe opioid use disorder and cannabis use disorder. And the issue I am bringing before you is in these rural communities, some are very robust. They have robust recovery support models, and some have none. And this particular community has no recovery support at all. And in fact, the closest is about 35 miles away. And our presence is not there in the school. I will see these kids by Zoom if I've been able to send home drug test kits, because I won't see them without testing them. And I see them in person pretty much every other visit. When they first started coming, they came in the end of April. The youngest one had gone through withdrawals, and the mother took him to his primary care provider, and they sent them to an emergency room, and the emergency room that he went to referred them to us. And when I started seeing them, they came because they wanted to stop the withdrawals. They are no longer selling because they are pretty isolated, as far as I know. I'm not sure about the older one, but that's what they say. And their use had gone down. They liked the Suboxone. They felt like it was helping them, especially not withdraw. And they said they never wanted to use again, but they continued to use THC. But their drug tests were only negative for fentanyl for about a month. And then recently they've started using fentanyl again, even though their mother is observing them and making them take their Suboxone in the morning. She's not aware that they're still using cannabis. And they share, they just seem, I asked them, so what is it that you get out of this? Do you get high? And one of them says, no, we don't really get high. And the other one says, yeah, it makes me feel relaxed and cool. And I said, so why are you using again? Even though you didn't want to? Well, because it was such a part of our life and we like the feeling. And I can do so much. I talk to them. They're very engaged with me. In fact, I have appointments with them in about 30 minutes. They visit with the coaches. Our coaches are adults. They're not young adults, but they talk to the kids quite frequently. But these kids do what they want to do. And I feel like, because my background, my whole research career, everything has been with recovery supports. And what I know is they need to have a group of people, peers, who value not using before they will really engage and want to not use, because they are not at all motivated to stop smoking weed. They're not at all motivated to stop smoking nicotine. And the only reason they don't want to get back into Percocets is because of the withdrawals. So I just am bringing before you to see if you have any suggestions that perhaps with these rural youth, if you know of any. I guess I'm not supposed to say the town that they're in, or can I tell them the town? Because maybe people know if there's some resources up in that area. I don't know.
You mentioned the town is fine.
They live in Cleveland, Texas, and Cleveland has a huge problem with the presence of fentanyl in the schools. In fact, the very first week of school, they had 8 overdoses in the bathrooms. In that first week, the school has done a robust effort to try to prevent. They have Narcan in the schools, but it's very prevalent. And these kids are a part of a drug using culture. And that's it. They have their family who right now, mom's got her finger on them. She's not working, but she's going to be going back to work in the fall. The kids are pretty much getting away with what, even with her being home. And they just don't have much motivation. And my experience is motivation comes from seeing others who are doing well, who are just as bad as them. But there's not an NA meeting anywhere in Cleveland. The closest is in Conroe, which I understand is about 35, 40 minutes away. And I've talked about online programs and they're not interested. And so I don't know if anybody knows much about that area or has some suggestions for getting some resources to these kids.
Thank you so much, Dr. Nash, for sharing this case and bringing this to us. I see Dr. Clancy, you had a question or a comment.
Hey there. So I actually went to both of the town halls in Cleveland when they first had the overdoses. And I'm the director of the Houston Recovery Initiative. We have work groups focusing on many different patient populations, one being adolescents, of course, one being family members. There was another organization there from Montgomery County, the Montgomery County Overdose Prevention Endeavor. Montgomery County also has the Behavioral Health and Suicide Prevention Work Group, which again has a young adult work group and has an addiction work group. Liberty County, I believe that's the county, right? Like
Yes, that's the county.
Yeah, so they are not mobilized like their neighbors. It's very difficult to start groups, right, that can push initiatives like the two I just mentioned. It's really important for parents and community members in that area to join the groups that are around them so that they can see what resources are available that they can borrow, and then they can build a group in their area so they can build up the resources there. The problem is it's really like a desert. Like, I can't believe there's a mega multi-million-dollar high school in the middle of nothing. It's interesting. The children in that area are going to continue to be at risk because of the drug highways that run through it and the large amount of construction. So there's a lot of trafficking, and what happens with the kiddos, in addition to them not having a tolerance, they're getting a really contaminated drug supply that can be bottlenecked in that area. Yeah. This isn't something that's going to go away, unfortunately, and the parents and community members in that area have to get mobilized. It's been really difficult to really, for any area or organization, when there is not data sharing about the severity of the problem, people don't necessarily see the need unless it happens to their kid. So it's just an ongoing issue. I have been out there a couple times. The CDC Foundation has a program trying to reach the individuals, but as you mentioned, the 20-something overdoses that happened in the first month, like eventually it's going to be a fatality. And sometimes that's what it takes to get a community mobilized. But there are virtual opportunities for them to organize and learn about resources in their area right now. It's just hard to reach them when there's not a lot of information sharing between the schools and the parents and the community at large. And I think that this county is not unique with that, especially in Texas.
One thought I had, all my work was with youth that were in recovery, is that it's the at least the 12-step programs are all volunteer run. I don't have an in to the smaller towns around that have NA meetings, but I was thinking if somebody who knew about those NA meetings, if they could talk to some of those programs, maybe they could start a program in Cleveland, so I don't know. I have
I'm-
a lot of intake in Houston, but nothing in those rural areas.
I'm happy to look into it. I do know they had a teen-focused recovery group in the Woodlands before the pandemic. I'm not sure what happened to that, but I can look into that also and
Thank you.
find out.
Thank you. Did you take Leonard's position? Are you in his position now?
Yes,
Okay,
pretty much.
nice to meet you.
Nice to meet you too.
Yeah.
Thank you so much, Dr. Clancy. I see a few comments here in the chat. Thank you, Dana, for you mentioned about RTC 3H pathways, and that is located in Mountain Home, Texas, and that's a good place for the children as well.
What's it called? What's it called?
It's called RTC. We can share this information, Dr. Nash, in an email after, if that's helpful. Yeah, we can definitely do that. I see your hand up, Rachel. Would you like to unmute and please share your comment?
Hi, yes. Mine is kind of like a two-part thing. First, I wanted to just ask, have you thought about possibly increasing their Suboxone dose? Because it could be that their cravings are not being met. And then also if they continue to use fentanyl, then you would definitely benefit from increasing their dose to give them that extra protection. I know you said that they're on 8 and it says that they're supervised dosing. So I wasn't really sure like what if that's the reason why you haven't been able to increase the dose because you want to have it supervised. And then the second part is, have you addressed what it is that they like about marijuana? Because a lot of times people, you know, they're self-medicating, right? So like, it helps my appetite, or it helps my anxiety, or it helps my sleep. And so just addressing and trying to figure out what alternatives there are so that they don't feel like you're just telling them you have to quit everything, you know, and finding other options as well.
So these kids do not seem to have any mental health issues. Most of the kids I've seen do. But these kids use because they like it. It makes them chill. My hesitation about increasing their dose is simply they are little. The 15-year-old weighs about 80 pounds. His brothers weigh in the 90 pounds things. And I could definitely increase it because they're taking, they said that they used a pill amongst themselves 2-3 days this past week. And that's the max that I get because they don't all tell the same story to me. But so they're not using as much as they were using before. But that was actually my hesitation about increasing the dose.
Or I might even try changing it from an 8 to 2 4s. And then that way they can, you know, take one dose in the morning and then the second dose more towards the evening. And that way, if you want to increase, you could just do another 4, which would be a total of 12. And that way they're taking morning, noon, and evening. I think a lot of times it's more a habit, a mental thing where people are just so used to using drugs throughout the day. So the Suboxone then can become their new habit where it's all right, it's time for me to take my medicine, you know? And so, and also the 4s, I feel like there's less chance of them diverting it. You know, because the way Texas is right now, the 8s are what sell more than the 4s. So that might be another option as well.
Yeah, I mean, I could think about that. The issue I have, I mean, there is a pharmacy there that I'll just have to make sure that they carry them there.
This is Alicia, Dr. Kowalczyk, and I would strongly encourage you to increase the dose. I mean,
even with those small weights. Okay.
Even with the small weights, I mean, they're using fentanyl. So you're giving a partial agonist and you're worried about that, and they're using fentanyl. That's much more likely to kill them. I mean, they're on essentially a subtherapeutic dose. If they're using, that's what that's telling you. And I think it's fine if you want to dose it twice a day to give that kind of, you know, replace one habit with another. I think that's a great idea, but I would strongly encourage you to increase dose. I mean, it used to be, we said 8 was kind of the minimum, but with fentanyl and the drug supply and the physical dependence that comes with that, we're usually seeing 16 is pretty necessary for most as a baseline, and 24 is not so uncommon anymore. You know, I know, again, when you read some of the SAMHSA tips and stuff, they still have kind of 16 is going to be good for most, but that was pre-fentanyl, and there's papers out there since 2020 that really support people on lower dose are not going to do well. And again, just think about what they're doing on top of this, right?
Yeah.
So it's not the Suboxone that's going to cause their respiratory depression, it's the fentanyl they use on top.
Yeah, okay, thank you.
I would be more aggressive with the dosing personally.
Okay.
I think that would go a long way. We also know that, you know, just non-therapeutic medication treatment is not very successful for OUD treatment long term. It's a great adjunct and support, and I agree it'd be great to get them some support within their own community, but the dose, yeah, I would increase the dose.
Perfectly, thank you, Alicia, appreciate
No
it.
worries. Thanks for bringing this case. It's really fascinating. Appreciate it.
Could I just ask a quick question about?
Oh, sorry, Dr. King, go ahead. But I agree with everything Dr. Kowalczyk said.
Thank you.
Yeah, me too. But you know, this is challenging. So are they getting homeschooled, or
They're out of school right now, they're in the summer.
well, but I mean, what's
Yeah.
mom planning
The
on doing?
plan, she said the 17-year-old, she wants him to get his GED. The 16-year-old wants to do the same thing. She just doesn't want him to go back to it is a terrible environment, but they're sitting them at home. They're obviously, now I haven't shared with the mom of their use because of my confidentiality thing, and but because it's gone on, they had stopped using fentanyl. And this is just recently in the past month that they've started reusing. And so, yeah. But her plan is to try to get them into some kind of training that doesn't involve going back to Cleveland High School.
I see.
Yeah, she was going to try to move them to another town, New Caney, nearby. Then they had a flooding up there, and now they don't think they can sell their house, so they can't move, and she can't get them in the schools unless they live there.
Man, yeah, that is tough.
It's tough.
Well,
Thank you.
okay. Well, Shreya,
I will increase the dose today. I'm seeing them in just a few minutes, so.
Yeah, yeah, we can move on to summarizing the case, but just before that, I just want to thank you, Dr. Nash, for
Yeah.
bringing this case to us. And you know, it is a challenging case, and thank you so much for sharing that. Dr. King, if you could please help summarize today's session and the case.
Sure. So this is a very interesting case for us. Unusual, a trio of brothers, all minors with very severe substance use problems, being treated with buprenorphine for fentanyl dependence problem. And I think the biggest challenge that the treating provider is having is trying to figure out how to sort of get a handle on some kind of sober supports when it seems like sort of just out in the middle of nowhere, and in a very strong drug culture that really makes it very difficult to figure out where to start. And Dr. Clancy gave some very interesting viewpoint, I think, of trying to figure out how to perhaps mobilize the community. Or I think we also saw some suggestions in the chats about sort of self-help groups that might be, in that area that might be enlisted to help, perhaps get a youth, a younger kind of self-help group going. Again, it seems like it's sort of difficult to know who's going to spearhead that. Do you think mom might be interested? Would she have time or inclination to help with something like that? Or again, is it hard because she thinks they're doing fantastic? and it's not, she doesn't really know that they're still pretty much using a bunch. So anyway, I think if, at least the consensus is that if we could get some kind of idea about some local resources that might be able to help. And who knows, maybe going up on the medication may be helpful, at least in terms of their desire to continue using, because they'd be less likely to actually get any kind of drug effects. But one wonders, what the trajectory of these boys is going to be if they're trying to hold some just sort of basic jobs, fast food or whatever. Do they have, and I guess another thing, do they have any aspirations?
Yeah, they do. They each have different aspirations. And I've been doing a lot of MI, talking about different options. One of them wants to do welding. One of them wants to be a mechanic. The other one just wants to make money. So he's 50.
Yeah. Well, I think, again, that's another way to get folks motivated for things other than drug use. If you can't go to welding school if you're high at home. So yeah. And as with many of these things, I think it's great to have a treatment provider, somebody who's a consistent supportive figure to help them sort of through that. Do you think it interferes with, I'm sort of going over, I'm sorry, but it just occurred to me, do you think it may interfere with their individual sort of progress with just seeing you one person? Would it be helpful perhaps, having them see, different people? I'm just curious. I don't know whether it would or not.
When they see me, they see 2-3 different recovery coaches. They have a counselor. They have a counselor, not the older two don't want to see the counselor. The youngest one engages. Yeah.
I see. Well, very interesting. Thanks for bringing that. It's very,
thank you a lot.
Very
I appreciate your input.
Thank you so much, Dr. King, and thank you all again for joining today's ECHO. As a reminder to earn CE credits, please text the activity code 1009-5940 to 844-502-1338 by midnight tonight. I do understand some of you are having trouble with the code today, so if you continue to have issues, please do email us at cstat@utisca.edu and we can help you out with getting the CMEs for today's session. We also request you to complete the post-session survey using the link in the chat. The survey link will be open for 1 week. If you would like to present a case, please email cstat@utisca.edu. We look forward to seeing you at our next session on Tuesday, August 20th. Thank you and have a wonderful rest of your day. Have a good one. Bye-bye.